Our next speaker is Dr. David Notrica. Dr. Notrica is a graduate cum laude from Duke University and afterwards graduated from Emory University School of Medicine, and he's a member of the AOA Honor Society from there. I would say that Dave is a born leader because he was president of his medical school class and has been very active in different societies in Arizona and nationally. He's also been identified by multiple groups as being one of the top pediatric surgeons, and in the listing of the top 1% of pediatric surgeons in Phoenix, he came out rated in that group. He's also developed and continues to direct the Level 1 Trauma Center for Phoenix Children's Hospital in Phoenix, Arizona. And Dr. Notrica will be talking to us about liver and spleen injury, who fails non-operative management, and why.
I appreciate that introduction. You think after this many years that I would learn not to follow Todd Maxson after a talk. Let me borrow that one.
Sure.
I was worried he'd taken it with him. So we're going to go through in English what is called the who, what, when, where, and why of failure. I apologize because one of the things that's failing is my voice, so I'll do the best I can. Non-operative management of blunt liver and spleen injury in kids has become kind of a standard of care. Same thing for kidney injury. But failure does still occur, and it's time to start asking questions about why kids fail non-operative management. And so who fails, what predicts failure, when do they fail, where do they fail, and then why do they fail? And the short answer is that not very many people, not very many kids fail non-operative management. The literature says that it's about 5% in pediatric centers, and that was one of the benchmarks set for isolated injury by the American Pediatric Surgery Association. But in the United States as a whole, we never got close to those numbers. So as a nation in the U.S., it was still 9% to 15% failure in isolated injuries. And for the pancreas, it was 18%. For the spleen, it was 4%. Liver, it was 3%, and kidney was 3%. And that's what we were seeing at the pediatric centers. But that's not what we were seeing for the entire U.S. So there was a big discrepancy. I was part of a group called the Atomic Group, which is a consortium of pediatric trauma centers that did a prospective study to look at the failure rates. And we enrolled 1,000 patients with blunt liver and spleen injuries and over a 3-year period. And what we found is that about 7% of patients fail non-operative management, but it's certainly very much lower for isolated injuries. So when you look at those patients who only have a liver injury or only have a spleen injury, no isolated spleen injury failed in this study, and there were 173 isolated injuries. Not very many grade 5s, because there aren't that many grade 5s, but the grade 4s, about 42 of those, none of those failed. When it came to liver, we did see a bit more failures. We even had some low-grade injuries fail, which was quite surprising for us. But overall, the failure rate was about 3.8% for isolated liver injuries. We know from other studies that there are certain things that are associated with failure. Bicycle crashes significantly increases the risk by about 1.8 fold. Falls are protective, so if you have a child who falls, they're actually unlikely to have to need surgery for their injury. And then motor vehicle collisions, motorcycle collisions, sports and assaults are all about average. So if you look at the risk factors, one of the biggest risk factors that we found was combined liver and spleen injury. And so if you've injured just your liver or just your spleen, it's not as bad as if you've injured both. Contrast extravasation on CT scan was initially thought to be not predictive in kids, but with this larger study, we actually showed that if you have a contrast blush on CT, you are a little bit more likely to fail. Not tremendously, but a little bit more likely. Transfusion is a risk factor, and then time from injury to transfusion is also a risk factor. So if you need to get transfused early, you're more likely to fail. It makes sense. High-grade injuries, when you talk about the grade 4 and grade 5 injuries, a grade 5 injury is 58% 58 times more likely to fail than a lower grade injury. If you have multiple injuries, so your injury severity scale is increased, you're 15 times more likely to fail. If you have a bad head injury and you're in a coma with a GCS less than 8, that's also predictive, as are multiple injuries, which we talked about before. The things that are not predictive are things like grade of injury in the low grade. So the grade 1, 2, and 3 are about the same risk of failing within that grade. That doesn't extend beyond grade 3. Age doesn't seem to matter, and gender doesn't seem to matter. Hypotension at admission is really important, and that's one of the things that we built our algorithm around, and so we'll talk a little bit more about that at the end. Transfusions, patients that are transfused are more likely to fail. If you end up needing a hepatic artery angioembolization, that's predictive of failing non-operative management. If you have peritonitis at the first exam, if your initial hemoglobin is less than 8.5, that's a risk factor for failing non-operative management. Also, large hemoperitoneums on the CT or the ultrasound, and hypotension without a preoperative blood transfusion is likely to fail. That's important because if you think about it, that's a patient who comes in with a low blood pressure and gets whisked off to the OR without ever getting blood before they go to the operating room. What predicts success? Isolated spleen injuries? Absolutely. Isolated injuries are helpful. When it comes to failure in kidney injuries, what we know is that if you don't have contrast in the ureter, that's more likely to fail non-operative management of a kidney injury. If there's a big separation between the upper and lower poles of the kidney, that's predictive. If you have multiple areas of extravasation, so more than one area that's leaking urine, then transfusion is also predictive. What's not predictive is the diameter of the extravasation. So if you have a big hematoma around the kidney, that doesn't predict that you're going to need an operation. And the location doesn't seem to be predictive as well. There were some initial reports suggesting that location mattered, but apparently location does not matter. When it comes to predicting failure in the pancreas, patients with high-grade pancreatic injuries are more likely to fail, and we'll talk a little bit more about that in a minute. So when do they fail? Dr. Holcomb told us earlier about adults failing, and we know that adults fail within the first day, and I thought that was interesting. But they do continue to fail after the first day, as shown by this graph. This was a Peitzman study. Kids, by contrast, fail really early. So the median time to failure for a pediatric patient was 3 hours from arrival, and about 40% had failed by 2 hours, 60% by 4 hours, and by the time you hit 12 hours, about 3/4 of the patients who are going to fail have already failed. We looked at this with our prospective study as well, with 1,000 children. The mean time to failure for hemorrhage was 3 hours post-injury. Now, this is post-injury numbers, not post-arrival numbers. So the numbers I gave you before were time of arrival. This is from time of injury. And so I think it's really telling how steeply this curve drops off, but it's even more telling if you look at the red line and see that those that fail for bleeding are all failing very, very early. So where do they fail? This is the study that makes me very unpopular with adult trauma centers, because the truth is that they're more likely to fail at adult trauma centers. There's some studies that show that they have the same outcomes, and I think that there are definitely adult trauma centers that do have the same outcomes as pediatric trauma centers. Nice paper, teen trauma without the drama, showed that the results in Ohio were the same. And they concluded that there were similar outcomes for length of stay, ICU, and survival. But they didn't really look at non-operative management as an outcome, and I think that that's an important outcome. The Pennsylvania trauma system also showed that first of all, teens are taken care of at a lot of adult centers. But if you look at the pediatric trauma centers, they had less frequent emergent laparotomy for their patients, so it's protective by a factor of 0.65. So a standard risk factor would be 1.0, and 0.65 would be a 35% less chance of needing laparotomy. A paper that's getting a little bit older now, but certainly showed how things were in 2006, They looked at 80,000 patients, and they said that the odds ratio for a splenectomy of a pediatric patient at a trauma center versus a non-trauma center, twice as likely to have a splenectomy at a non-trauma center, 2.8 times as likely to have a splenectomy at a general hospital. If you're taken care of by a general surgeon, you're 4 times more likely to have your spleen taken out than by a pediatric surgeon, and an adult trauma center was 6 times more likely to take the spleen out than in a pediatric trauma center. And that was 2006. A JAMA article looked at another 2,800 patients, and they adjusted for patient characteristics and injury severity and hospital characteristics, and the risk of splenectomy was still 5 times higher in adult trauma centers. And you have to ask why that is, and what they found is that there's a difference in tolerance for non-operative management between adult and pediatric surgeons. And they gave standardized scenarios to adult providers and pediatric providers, and sent it to people who take care of injured kids, and clearly there was a difference. That difference is now finally starting to disappear over time, but it took a long time, and it took a lot more education and rehashing of that these kids will do well without surgery than we initially appreciated when we started trauma. There's no reason that an adult trauma center cannot match the results of a pediatric trauma center. So why do they fail? It's a bad sign when you have 3 attending surgeons operating. This is my partner, Dr. Mark Molitor, and Dr. Craig Egan, and I operating on a bad liver injury. Most common cause of failure is shock, followed by peritonitis, followed by continued bleeding, which is not necessarily shock, but certainly a failure to stop bleeding, intestinal injury, and then pancreatic injury. And then diaphragm injury and bladder injury are also on the list, although much lower. So if you look at the operations that they require in this study of 1,000 patients taking care of at pediatric trauma centers, 19% underwent splenectomy, 10% went hepatophy, 8% had to be packed, and 3% underwent splenic salvage, and 1 underwent a partial removal of the liver. If you look at the patients who failed for reasons other than bleeding, certainly intestinal resection and pancreatic resection were the main causes. There were a few cases that were operated on for mesenteric injuries, diaphragm repair, and diagnostic laparotomy. There are less frequent causes of failure, including intra-abdominal compartment syndrome, which we sometimes see in kids. This was a child who had a liver injury and a bile leak, who basically couldn't tolerate the swelling in the abdomen, couldn't be ventilated. That's what we found at surgery. There's also a report of duodenal obstruction by hypertrophy of the left lobe of the liver, so rare causes. More commonly, though, we see things like continued bleeding. And if you have a splenic blush in the adult patients, you need to embolize that. But nice studies now show that in pediatric patients, routine splenic artery embolization doesn't improve splenic salvage. It may, however, be an alternative to splenectomy in a limited number of patients who are otherwise failing non-operative management. If you look at all kids who have contrast extravasation, that's about 6.5% of kids. There's no association between that blush or contrast extravasation and delayed bleeding, mortality, length of stay, or the need for transfusion. You'd think that angiography would be, and embolization would be the end of this discussion. You embolize it and everything is fine, but the reality is that of 32 kids who underwent angiography, 19 underwent embolization, and a third of those failed non-operative management anyway. We worry a lot about delayed splenic bleed as a cause of failure in these kids, and there have only been 14 cases of delayed splenic bleed reported in the literature. The mean age was 14. 7 of those 14 cases actually are not really delayed splenic bleed. They're actually delayed presentations or continued bleeding. In the study that tried to peg the incidence, it was done here in Toronto, of all places, which is nice. They had one patient who was a 15-year-old who had a grade 4 splenic injury. They presented 23 days later with a delayed splenic bleed that caused death. And they looked out at their numbers, and they'd had 300 successful managements prior to that, and so they concluded that the incidence was probably about 1 in 300. I would argue that the incidence is probably 1 in 600, because the reality is you don't pick that ace of spades out of the deck on the number 52 card that you pull. You basically pull out that ace of spades right in the middle of the deck, or 26. So it's probably about 1 in 600. We worry a lot about splenic pseudoaneurysms. I will tell you that splenic artery pseudoaneurysms are not the same as splenic pseudoaneurysms within the spleen. What we see here is on the top picture is a splenic artery pseudoaneurysm, and on the lower picture, a splenic pseudoaneurysm within the spleen. And they're not the same as hepatic pseudoaneurysms, which actually are more likely to bleed. If you look at the studies in kids with pseudoaneurysms, there are about 45 patients reported. In one series, they watched them. They observed 9 patients, and 8 of the 9 patients basically resolved without any intervention. In the study that embolized them, there were a lot of failures, and those failures resulted in splenectomy. A good portion of those did resolve with embolization. And what we ultimately find is that the natural course of splenic pseudoaneurysms is not what we thought it was. Durkin et al. Studied every patient with a splenic injury with contrast-enhanced ultrasound. They re-imaged every patient. They had 43 patients, and 9% of the patients developed splenic pseudoaneurysms. This is what it looked like. This is a cool study because it's a contrast-enhanced ultrasound, and I think you'll be seeing more about that in the future. These pseudoaneurysms were identified on day 5 of admission. All of them were asymptomatic. None of them were embolized, and they all resolved by thrombosing spontaneously. The median time to resolution was about 8 days. In the atomic prospective study, we had 1,000 children with liver or spleen injuries. We had no cases of delayed spleen. That's about 500 spleen injuries, no delayed spleens. There was only one delayed bleed of any kind, and that was a patient who developed hemophilia from a liver injury, and it presented as an upper GI bleed. We worry about liver pseudoaneurysms. They only occur in about 1.7% of liver injuries, and they're usually associated with high-grade injuries like grade 4 injuries. And in one series that identified 3 of them, 2 of them developed delayed hemorrhage that required urgent treatment, so they're a little bit more worrisome than spleen. Keep in mind, though, that these are really very few cases, and it's hard to make recommendations on them. What I can tell you is that we don't know enough to not recommend re-imaging those patients. Kids with liver injuries can also fail from major ductal injuries, and so we now manage most of those in a non-operative fashion with ERCP, PTC, which is percutaneous transhepatic cholangiography, and CT-guided drainage. But some of those will still fail, and those failures, most of them are elective and consist of laparoscopy and washout of the abdomen. Kids get a tremendous amount of pain, which they don't tolerate very well, and if you can put a scope in there and wash them out, make sure your drains are in a good position, they'll recover more quickly. When it comes to renal arteries or kidneys failing, most of them that do fail for hemodynamic instability, persistent bleeding. A small percentage are going to fail for UPJ disruption, so the ureteropelvic junction gets torn. Some of them will fail for abscess or clot retention. Again, it's the high-grade injuries that fail. The low-grade injuries do pretty well. If you look at the study by Umbrich, they do a nice job of separating out where 11% failed for hemodynamic instability. Urinomas was about 17% of their failure, and then 72% of them actually did not require surgery. When it comes to peritonitis, those patients with an intestinal injury need to be operated on. Initially, there was some concern that we shouldn't pursue non-operative management of liver and spleen injuries because we were going to miss some intestinal injuries. And this was kind of an argument against non-operative management. But now there have been several studies that show that there's no need for urgent exploration when the diagnosis is in question. You can do serial abdominal exams and pick these patients up adequately without increasing their morbidity and their mortality. I told you earlier we talked a little bit about pancreatic injury. Blunt pancreatic trauma tends to require operative management more frequently than other solid organs, and the non-operative management failure rate is reported at 16 to 26%. Last year I spoke at this conference about the truth about pancreatic injury, and I'll just hit the highlights. Non-operative management of a pancreatic injury does not mean that you saved the pancreas. Mm-hmm. If your distal duct is transected, everything that's beyond that transected distal duct is going to go away. It's going to dissolve, and so if you're willing to sacrifice that amount of pancreas by letting it autodigest, you can manage that patient non-operatively. But don't think that when you go back and restudy it that the pancreas is going to be there. It's not. It's going to be gone. The failure rates and complications are higher with non-operative management than with operative management. There is a tendency for grade 3, 4, and 5 injuries to do better if they're managed operatively, and that doesn't just mean take the pancreas out. There are 2 reconstructive operations for saving the pancreas. One is a pancreaticogastrostomy. So if you can imagine, we take the end of the pancreas, that's the distal part of the pancreas, and we reimplant it into the stomach. That's a very common cancer operation that's done now for central pancreatectomy. That saves a good portion of the pancreas. And then pancreatico-Roux-en-Y jejunostomy is another option where we basically use the intestine to reconstruct the drainage for the pancreas. Those both offer the opportunity to retain the pancreas that is beyond where the duct has been injured. So what can we do to decrease the amount of non-operative failure? Written protocols are clearly important. A lot's been written by Peitzman et al. Saying that if the centers were using protocols and had better adherence to sound clinical judgment, that we could reduce the incidence of non-failure in adults. The pediatric surgeons have been working on this for a long time. Stilianos and the APSA Trauma Committee set benchmarks. In Arkansas, Sam Smith taught us to treat based on hemodynamic status, not on the grade of injury. Kansas, Sean St. Peter taught us that it's safe to do that prospectively. Atomics gave us an evidence-based guideline for how to do that, and that's been published in 3 different journals now. And APSA is working on a new guideline based on the Atomic guideline. The goal of that guideline is to improve non-operative management. It generally looks like this. We divide patients into stable patients and unstable patients. If you're stable, you get hospitalized until you're not clinically bleeding, and then you go home the next day. If you're unstable, you don't get this much crystalloid. You get maybe 20 per kilo crystalloid, maybe 0. And then you go to packed cells. If you don't respond, you go to the operating room. You failed. If you respond transiently, if you respond transiently and then fail later, you failed, and you need to go to the OR. It's the patients who have a sustained response to packed red blood cells who have the best chance of being managed non-operatively, and this algorithm will help you achieve that. If you get to 40 mils per kilo of blood or 4 units of packed cells, you're likely to fail. And that's a good cutoff and a good threshold, and I think it's something that you can wrap your hands around to decide who's failing and who's not failing. So in conclusion, who fails? Not many, 7% of children. Age and gender don't matter. Pancreas injuries in patients with grade 4 injuries are more likely to fail. If you have contrast extravasation, you're slightly more likely to fail. Angioembolization, you can save some, but a third are going to fail anyway. And if you have an isolated splenic injury, you're very unlikely to fail non-operative management. Combined injuries where you've injured the liver and spleen are more likely to fail. Same thing if you combine a kidney injury with that. Bicycle injuries, hypotension and non-responders, they need to fail because they are not good candidates to continue to manage. If you have a high ISS, a Glasgow Coma Scale. When do they fail? They fail earlier than adults, typically within 3 hours of injury, if it's for bleeding, or within 5 hours if it's for other reasons. They fail at non-pediatric trauma centers or centers with non-pediatric surgeons. I don't think that this should persist. I think that this is temporarily starting to go away, but it needs to go away completely. We need to redo this study 10 years from now and say, hey, you know what? It turns out it doesn't matter where you get cared for. As long as you follow the protocol, you had the same success rate of any place. This is completely portable. No reason it should be different. 3.5% of patients fail for bleeding. It's usually continued bleeding and not delayed bleeding. 3.5% for other indications that need surgery, like pancreatitis, bowel injury, pancreatic injury, bladder injury, diaphragm injury. Lack of a protocol causes patients to fail, and differences in trainings and tolerance for injury. A lack of tolerance for injury is probably the #1 reason that they fail. Thank you. I'll take any questions.